Okay, so I'm very pleased today to welcome Dr. Huiyun Xiang, who is a professor of pediatrics at Ohio State University College of Medicine. He's director of the Center for Pediatric Trauma Research there, and he's also director of the Research Core and associate director of professional development and director for international programs of the Center for Injury Research and Policy at the Research Institute at Nationwide Children's Hospital in Columbus, Ohio. He actually has a long association with Colorado. He did a postdoctoral fellowship with Lorenz Stallings up at CSU with the Colorado Injury Control Research Center. Julie was there at that time as well. And then from there, he went to be unit director of the Vital Statistics Unit at the State Health Department here in Colorado, and then subsequently went on to Ohio. He has trained more than 30 undergraduate, graduate medical students, postdocs, and visiting scholars. He's been on a number of national and international committees and organized conferences. He's currently on the boards of, I think, 6 different injury journals, including the one I can manage that we are on together. But that's all just what he does in his spare time. He has nearly 150 peer-reviewed publications, studies on injuries in children, agricultural workers, skiers and snowboarders, etc. Current research projects include federally funded studies of drug poisonings and injuries among U.S. workers with disabilities, as well as the national study of undertriage of trauma patients, on which he will be presenting today. So please welcome Dr. Xiang.
Thank you, Karen. This is a very nice introduction. When I came to Denver, it's like I came back to home, so we have a lot of friends here. I want to thank you so much for coming to my presentation today. So what I will share with you is some preliminary results of our national study of undertriage. The title of my presentation is Undertriage of Major Trauma Patients in U.S. EDs and Increased Mortality Risk. I will talk about background and significance of undertriage of major trauma patients, and then I will talk about hypotheses and the research questions of the national study of undertriage of trauma patient. And then I will share with you some preliminary results. And finally, there are a lot of questions and answers. I want to have a dialogue with you. I do not know all of the answers. There are a lot of questions there. We can have a discussion. So, you may know this regionalized trauma care in the U.S. The idea of the regionalized trauma care is to match trauma patient needs with the available resource and provide expertise to achieve optimal patient outcome. That's the philosophy, that's the idea behind this regionalized trauma care. In the United States, trauma centers are classified into these 4 levels. Highest level is the level 1 trauma center, such as Denver Children's Hospital. It's a level 1 trauma center. So these hospitals, those trauma 1 centers will provide comprehensive resource, capacity to treat most severely injured patient, and leadership in education and research. That's the level 1 trauma center. Nationwide Children's Hospital is one of the pediatric trauma 1 centers. Level 2 centers. The only difference between level 1 and 2 is level 2 centers do not provide leadership in education and research. Level 3 centers usually provide prompt assessment and resuscitation, emergency surgery, and if needed, need to transfer those most severely injured patients to the level 1 and level 2 centers. Level 4 and level 5 usually are state-defined and often are located in remote areas. Those centers have many similarities to non-trauma medical centers. Their primary responsibility is to do this prompt assessment and stabilization, and then they need to transfer those most severely injured patients to the higher level of care. That's the concept. And then there are guidelines for field triage of injured patient. Experts recommend the following steps to trying to identify those trauma patient who need high level of care. The first step is to measure the vital signs and level of consciousness using CAMA score and vital statistical signs. And second step is to assess the anatomy of the injury. Penetrating injury, skull fracture, and chest wall instability and paralysis. Those injuries have significantly higher mortality, so they need to be transferred to the highest level of care. Step 3 is to assess the mechanism of injuries and evidence of high energy impact, such as falls, high-risk motor crash. Step 4 is assess the special patient and all system consideration, old patient and children, anticoagulant disorders. So, within an ideal organized trauma care, patients with severe injury should receive definitive care at level 1 and level 2 trauma centers, while those with minor injuries should receive care at non-trauma centers or level 3 trauma centers. That's an ideal situation. So then what's the definition of undertriage? Undertriage means severely injured patient received definitive care at a facility not designated for the trauma care of severely injured patient. That's the definition of undertriage. So this map shows the level 1 and level 2 trauma center access in 2010 in the US. You can see there are a lot of areas in which there's no trauma 1 or trauma 2 centers. But if we put ED locations on the map, you can see there are a lot of EDs are receiving severely injured patient, but there's no trauma 1 trauma centers close by. Factors causing undertriage of major trauma patients in the U.S. Number 1, not all areas of U.S. are covered by regionalized care. Second, it's estimated that only 18% of injured patients who need an ED visit are transported by EMS in the U.S. This is sort of like a very low. So you can see a lot of people are transferred to the emergency room by the family member or friends who are not familiar with those field triage guidelines. So they don't know, the field triage guidelines. So third factors, guidance for field triage are not fully followed, particularly for elderly trauma patient. So it's an issue recognized by previous research. And finally, there's weather conditions and the patient preference factors there. So field triage and second ED triage. So when an injury happened, if it's a major trauma patient, could be transferred to level 1, level 2 centers by the EMS or by their family members. Some of them may end up in level 3 or level 4 centers or non-trauma centers. So at the ED of those level 3 and level 4 center, non-trauma centers, physicians will do assessment and will decide whether to transfer those patients to the higher level of care. You can see we have a two group of people here. One is the direct group from the injury field, and the second one is the transferred group from the lower level of trauma centers. Those we call appropriately triaged person. And there's another group, including ED deaths and those persons who were discharged or those persons who were admitted into the hospital without further transfer. We call that group undertriaged group. That's our primary concern and our primary group. One primary concern of undertriage of major trauma patient is the increased mortality risk at non-trauma center and level 3 centers, because those centers, they do not have resource and they do not have expertise to treat those most severely injured patient. That's the one side of the coin. Other side of the coin is the overtriage. Overtriage means you transfer those minor injured patient with minor injuries to a higher level of care, level 1, level 2 centers. And that means waste of precious resource and expertise time. I will not talk about that issue here. So my talk will focus on undertriage. Previous researchers did study and found out being treated at level 1 center in comparison to being treated at non-trauma center has advantage of survivals here. You can see this is a study. They look at mortality rate per 100,000 population in states where there was a trauma system and over those where there's no trauma system. You can see all injuries, unintentional injuries, motor vehicle related injuries, for all of those 3 injuries, incidence rate ratio is lower than 1, which means those patients who treated at in states where there is a trauma system have a better chance of survival. So, but you can see this did not specifically evaluate the trauma system. It's sort of like an overall population study. This is a very important study published by Alan McKenzie at Johns Hopkins University in 2006. They studied collect data from 18 states in the West area, Western region of the U.S. Compared adjusted case mortality rate, deaths in hospital, deaths within 30 days after injury, deaths within 19 days after injury, and deaths within 365 days after injury, and compare their fatality rate. You can see case fatality rate is significantly lower at the trauma centers versus non-trauma centers. And they did a further analysis, look at classify these patients into a group with maximum AIS score, abbreviation injury severity score less than 3, and maximum AIS score 5 to 6. So if you have an AIS score 5 to 6, means those patients are a severe injured person. So you can see the benefit of being treated at trauma centers only apply to those most severely injured patients here. For minor injuries, moderate injured patient, non-trauma centers can do a very good job. And then look at the value of trauma centers, and then they show that not only the trauma center can save life, but also they can save money. This is a meta-analysis paper comparing outcome of severely injured patients treated in trauma center versus non-trauma centers. Unfortunately, if you notice, this paper was published in 2005, so this paper did not include all the papers published by Alan McKenzie's group. But you can see here the odds ratio of survival at trauma centers 0.88. So it's very good to they have a better chance of survival at trauma centers versus non-trauma centers. But there are knowledge gaps. The first one is American College of Surgeons Committee on Trauma recommended less than 5% of failed triage in the U.S. But previous research found that this benchmark probably is impossible given the current practice model. But nobody has done a study to really look at that issue, to look at the national rate of undertriage. What's the rate here in the U.S.? No national study has invested that undertriage. There are some regional study in Pennsylvania and from other areas, but no national study has been done. No study has investigated the main diagnosis of those undertriaged major trauma patients. This is a very important issue. You have to know what are the main diagnoses of those major trauma patients who didn't go to level 1, level 2 centers. And then previous study investigated inpatient mortality within 30 days, 90 days, and 350 days, 365 days after injury. But no study has evaluated the ED mortality. So we designed this study called National Study of Undertriage of Trauma Patient, and we are lucky to got a grant from Agency for Healthcare Quality and Research last year to do this study. This study has several specific aims, two specific aims. The number one is really to design and test propensity score method for comparing ED mortality of trauma patients treated at level 1, level 2, level 3 centers and non-trauma centers. The idea is people use the propensity score to do two-group comparison, either level 1 versus non-trauma center or level 2 versus level 1 centers. But nobody has developed these three-group comparisons. That's the number one specific aim. But we cannot do the randomized RCT in this situation. You cannot randomly assign this trauma patient to trauma 1, trauma 2, trauma 3 centers. That's unethical. So you have to use the existing observational data to use statistical adjusting so you can have comparable group of patients when you evaluate their outcome. Otherwise, you are comparing orange and with apples, because those patients end up at trauma 1 trauma centers. They are more likely to be severe patients because of the field triage and second triage by the ED physicians. The specific aim too is to study characteristics of undertriage and the effect of undertriage on mortality at level 3 and non-trauma centers. From now on, I combine level 3 and non-trauma centers into, we call it non-trauma centers, because based on our research, really there's no major difference between level 3 and level non-trauma centers. We have some hypotheses here. Field triage rate is significantly higher than the 5% benchmark in the US. People guessed that's not achievable, but nobody has done a study to evaluate that. Second thing, hypothesis, elderly major trauma patients are at a significantly higher risk of undertriage than the 18 to 54 years old adults. That's based on the previous local study. Number 3 hypothesis, in order for those trauma 1, trauma 2 centers to absorb those undertriaged trauma patients, a substantial capacity increase is required. We did a simulation study to say, okay, the hypothesis is we should transfer all these most of the severe patients to the level 1 to level 2 centers. But we have to know what the capacity increase is needed for that to happen. Number 4, undertriaged major trauma patients have a significantly elevated risk of mortality at non-trauma or level 3 center EDs compared with level 1 trauma center EDs. And we have a research question, really is the research question, what are the main diagnoses of undertriaged major trauma patient? So is it just the scratches or minor, or what are the diagnoses? So we use the data called Nationwide Emergency Department Sample. But don't confuse this Nationwide Emergency Department Sample with our Nationwide Children's Hospital. So our Children's Hospital probably is participating in this, but this is a national database sponsored by the Agency for Healthcare Quality, Healthcare Research and Quality. This data set contains almost 29 million ED visits. That's over 75% of all ED patients in the U.S. Weights and the sampling variables are provided to generate national estimate. So this is the new data started in 2006, and they had a problem with 2006 data, but they finally fixed all of the problems. So the data available from 2006 until 2011 or now is 2011 data just came out recently. This data is very good for studies related to ED visit, if you want to do some research about ED visit. Definition of major trauma patient. We first use the injury severity score greater than 16 to identify major trauma patient. This definition of major trauma patient is consistent with the American College of Surgeons definition of moderate to severe injury trauma, the severe trauma patient. Previous researchers used this ISS cut point in studies comparing outcome between non-trauma and the trauma centers. And one study provided evidence that this is a good ISS cut point to select major trauma patient. Here is the slides they provided. I borrowed from their publication. Moham from Pennsylvania area did a published study last year. Look at the injury severity score distribution of those patients with minor injuries and those with moderate to severe injuries. You can see there's some overlap in the middle. But however, if we say we use injury severity score greater than 16, you can see almost 99% of our patient population are moderate and severe injury patient. So that's the concept of use ISS score greater than 16 to select major trauma patient. So it's the upper end of this population. So exclusion criteria, we then searched all 15 possible diagnoses and exclude those patients who only had injuries from native effects, superficial injuries, and injuries due to foreign bodies. This exclusion criteria is used by National Trauma Data Standard Patient Exclusion Criteria. That's their criteria. We borrow that. And then patients with unknown ED discharge disposition and those with unknown level of care were excluded because we have to know where did they go, where did they receive the care. Definition of undertriage, I said, is most severe injured patient received definitive care at non-trauma 3 or non-trauma centers. So that's what we, this slide show you the undertriage group, including those ED deaths and those who were discharged from the EDs and who were admitted into the hospital at non-trauma centers or level 3 or level 3 hospitals. Statistical analysis, we did a national estimate of ED visit for all major trauma patients. We calculate the overall undertriage rate, and we calculate undertriage rate for each patient characteristic. And then we use univariate and multivariate logistic regression model to estimate odds of being undertriaged by patient characteristic. And then we searched all diagnoses. Each patient could have up to 15 medical diagnoses in the database. We searched all 15 diagnoses and ranked the diagnoses by major diagnosis category frequencies for all undertriaged patients. That will give an idea what are the leading cause of medical diagnosis for those undertriaged trauma patients. And then we did a simulation capacity requirement analysis to try to assess the capacity requirement if we transfer all of the major trauma patients to level 1 and level 2 centers. And then finally, I will share with you some of the preliminary assessment result of mortality risk of undertriaged traumatic brain injury patients. So there's a reason for us to choose traumatic brain injury patient first. I will share that result with you. So using the 2010 NEDS data, we identified almost 50,000 major trauma patients. And there are two groups here. One is the appropriate triage group, and another is the undertriaged group here. So, based on that data, the field undertriage rate, the first triage, is 37.4%. You can see that's significantly higher than the 5% recommended by the American College of Surgeons. But if we consider field triage and the ED triage together, overall national rate of undertriaged trauma patients is still 34%. It's very high. So a lot of people end up at non-trauma centers. Here is the result of the national estimate of undertriaged patient and undertriaged rate. You can see, females has a significant, slightly higher rate of undertriage, and as age increased, undertriage rate increased dramatically, particularly for those people greater than 75 and over 85. And primary expected payer for their medical treatment, you can see those patients paid by Medicare, they have a significantly higher rate of undertriage. And median household income by zip code, we are still puzzled by this result. So those persons living in a relatively rich neighborhood, their rate actually is higher. So we don't know why. So maybe they live in the suburban areas somewhere.
Well, one of the things with the model that you're talking about, and you're just sort of alluding to, is where people live.
Yeah.
So, there's a general assumption if a lot of lower income folks live in an urban area, there are
closer
trauma centers all over the place.
Yeah.
So, and the same thing with all that data, are you controlling for geographic location? Because if you live west of Denver, you're not near a level 1 trauma center.
Yeah.
Or not, right. You're going to be undertriaged by definition.
Yeah, so we also look at the patient locations here, because the confidence interval overlap with each other. So the locations, appear not to be a significant factor there. I will show the result from our logistic regression. And then external cause of injury. So those fall event and those suffer from strike against, they have a higher rate of undertriage. So this is the odds ratio. We use the univariate model and the multivariate model. Multivariate model actually adjusts for those variables together. You can see gender is still risk factor, age is a risk factor. Chronic condition is a significant protective factor, which means those complicated cases, they are more likely to go to level 1, level 2 centers, which fits very well with our hypothesis or assumptions because they are complicated cases. They need to go to level 1 centers. And then primary care, so here, Medicare has a slightly higher rate of undertriage. Medium household income 1.65, but the confidence interval is 1.09 to 2.51. And patient location here, after we adjust for other variables, become non-significant variables. And it's a very interesting idea to look at admission on weekend. Because on weekend probably patient or doctors want to either do not want to transfer patient or want to transfer patient. Admission on weekend is not a significant variables for undertriage. And we use the motor vehicle crash as a reference group. If we use that as a reference group, a lot of these external costs, the rate actually is higher. So which means motor vehicle crash patients are more likely to go to level 1, level 2 centers compared to other type of cause of injuries. And this is a very interesting one. It's the capacity analysis for level 1 and level 2 centers to absorb those undertriaged patients. So the assumption is we should transfer all of the major trauma patients to level 1, level 2 centers. So let's review the current situation here. If we use ISS score to greater than 16, greater than 25, greater than 20, greater than 25. So we have the total number of undertriaged trauma patients. And then we have the current number of patients treated in level 1 and level 2 centers. And then we assume if we transfer all of these undertriaged patients to level 1 or level 2 center, what's the capacity increase is needed? Based on our simulation, you can say if we transfer all of the undertriaged patient with ISS score greater than 16, 51.5% capacity increase is needed. If we transfer all of the IS score greater than 20, 12% increase is needed. If we transfer IS score greater than 25, 6.2% capacity is increased. Based on this, probably we have doctors here, 51%. That's just not achievable here, given the current practice.
Is that 51% of the total trauma patient volume or total volume altogether?
The 51% of the total patient treated in level 1 centers. You have to increase your level 1 centers. So this is also very interesting. We look at the major diagnosis of this undertriaged patient. We look at those. We classify our patient into those who were admitted, who were routine discharged, and who were transferred, who left against medical service or died in the EDs. You can see for almost all those categories that close to 40% of those undertriaged patients had some type of traumatic brain injuries. Subdural, extradural hemorrhage, falling injury, fracture of skull, open wound of head, and those are the major diagnoses. You can see this is a total 40% of those undertriaged trauma patient had some sort of traumatic brain injuries. That's disturbing because we all know traumatic brain injury has a significantly higher risk of mortalities compared to other type of injuries. So we did analysis use the propensity score to compare the mortality risk of those undertriaged traumatic brain injuries. Here is the concept. like I said before, we cannot use RCT because it's unethical to assign patients into different level of care. Because if they are severely injured, they have to go to neighborhood. You cannot assign them to non-trauma centers. So here is the idea. Suppose we have 3 groups here. It's the level 1, level 2, and non-trauma centers. We can do an incomplete block design, which means we match patient from either level 1 center with those patients at level 2 centers. Or next we select a group of people from level 2 centers and match them with people at non-trauma centers. So this is a complete block design because you can see they are not really the same person when you do this 3-group comparison. Versus we have this complete block design, which means we match patients from all those 3 centers. So that's the complete block design. So this is the simple concept of there. So just give you an idea. I don't want to go to the detailed technical issues there. The hypothesis is after adjusting for covariates, undertriaged trauma TBI patient have a significant elevated risk of mortality at non-trauma EDs compared with level 1 center and level 2 centers. So this is our sample size. In order to increase our sample size, we combine 2006 to 2010 NEDS data. And we classify our patient into AIS score equal to 5, 4, 3, and 1 or 2. I mentioned before AIS score equal to 5, that's the most severely injured patient. You can see the crude rate at death rate at non-trauma centers is significantly higher significantly higher at non-trauma centers compared with trauma 1 and trauma 2 centers. But this is data without any justifications, adjustment. So which means, really you cannot compare them without any statistical adjustment. So here is the idea. So we use the optimal matching with the Mahalalabas distance, trying to find comparable patient. For each level of AIS score, we find a matchable. We match the patient. For example, if we have 736 patient with AIS score equal to 5, and then we found exactly the same number of patients from level 1 center and from non-trauma centers. We did the same things for AIS score equal to 4, AIS equal to 3, AIS equal to 1 and 2. So this is considered quasi-randomization. Do you have a question? Oh, okay. So this is quasi-randomization because this is not the true RCT designs, because we have to use the existing data. So here is, after the matching, we have to check the covariate balance to see whether they are comparable. I just showed the result for these following 4 variables: age, injury severity score, gender, and chronic conditions. They are considered significant factors that will have impact on mortalities. You can see after we matched, there's no difference between the groups, 3 groups. So which means those groups are comparables when we're trying to assess their mortality risk. So here is the preliminary result. We did the calculate odds ratio of ED mortalities and 95 confidence intervals. You can see being treated at non-trauma centers has a significantly higher odds ratio of death, so 3.90%. And for AIS equal to 4, this is 1.26, and for AIS equal to 3 is 1.5, and for AIS equal to 1 is 0.5. But here you can see these include the 1 in their confidence interval, so we cannot 100% sure, those the benefit is significant. So here, we show the result. Use this graph. You can see for most severely injured patient, their mortality risk is significantly higher at non-trauma centers. So in summary, at least this, this is a typo here. At least 34% of major trauma patients receive their definitive care at non-trauma center or level 3 centers in the US, which is significantly higher than the 5%. If we just consider if we just consider the field triage. Elder patient and medical patient at a significantly higher risk of being under-triaged. And in order to absorb those under-triaged patients, a substantial capacity increase at level 1, level 2 center is required. Such a significant capacity increase seems not feasible given the current practice patterns. Over 40% of under-triaged major trauma patients had diagnosis of traumatic brain injuries. And severe TBI patients at a significantly higher risk of death at non-trauma center and level 3 centers compared with level 1, level 1 centers. And I got good news from the American Journal of Emergency Medicine. They accepted this paper for publication, so I'm very happy. I want to thank my research team. I have research associate Krista Wiener. She joined my team 7 years ago, and I have Dr. Shi from China. He is working with me. He has been working with me for more than 3 or 4 years. And I have a PhD student. She started 1 year ago. And my collaborator are Dr. Jonathan Groner at the Trauma Program, Nationwide Children's Hospital, and Kathy Haley, and Trauma Managers at Nationwide Children's Hospital. And Dr. Bolo, he is the Associate Professor and Biostatistician at Ohio State University. I have to admit a lot of advanced statistical methods. I know some basic concepts there, but he's the person who really helped us to implement those methods. And finally, I want to acknowledge, I want to thank the Agency for Healthcare Research and Quality for giving us the grant. And thank you. I'm ready to answer your questions.
Well, I have a question that I'm sure you would expect, which is, why was level 2 better? Is that just we don't have a good enough way to assess severity? It looked like level 2 had better outcomes than level 1 for the most severe patients, which is probably not quite what we would expect. So I'm just wondering if there's some other explanation or whether they do a better job.
Yeah, that's this is the overall assessment. But we really need to do in the future is to what are the major factors to make them become a better, for the better outcome at level 1. Either it's because the physicians there they have guidelines, or either they have the trauma surgeons available 24 hours and 7 days, or whether there's a significant difference in terms of study protocols, whether they followed all that. Those requires further future studies. Yeah, that's a very good question. Yeah.
Just to respond to Carolyn's comment, the other potential factor is that, especially in a metro area, these sickest patients, of course, go to
Level 1.
trauma level 1 centers. So they're going to, seeing the sickest patients, they're going to have a higher mortality
So maybe
rate.
the matching doesn't quite take into account.
Yeah, so the matching can, there's a additional step. What we are doing is to using a sensitivity analysis. Our propensity score can adjust for those observed variables here, right? So in the database, but however, there are unobserved confounding factors. So we are trying to use statistical modeling to adjust that unobserved confounding variables. The idea is if the relationship between the trauma center classification and the better outcome remained if we adjust for the observed and unobserved variables, we can safely say there's a relationship between that and that. So we're doing that. So we have a promising result, but we don't have. There's a question.
I have a question on this issue of addressing the building capacity. When you showed the map, it was pretty startling. There are areas just without an total absence of these trauma level 1, level 2 centers. So to what extent is under triage, it's not necessarily a mistake or a choice, it's an environmental constraint?
Yeah, that's
how much does geography drive that under triage?
Yeah, that's a good point. It's almost impossible or not a wise investment of money to say we set all of the trauma centers, everywhere. So I think we should have a dialogue about this remote counseling. That's the one thing. People say telehealth. That's the one thing. Second thing is do a geographic analysis, geospatial analysis. Assessment need assessment. So my team is doing that. Use geographic analysis first to identify the populations in the neighborhood, and the second thing is to consider the injuries, injury burdens in the neighborhood, and to say where should we build new trauma centers. That's a very good question. I show the benefit of creating trauma centers, trauma 1, trauma 2 centers, but running those centers is very expensive because you have to have trauma surgeons, you have to have all the resources available. So what's the balance there? So how should we do that? I think we have to have a dialogue. That's an excellent question. Yeah.
Like when you separate out those under triage patients, that it seems to me that the discharge from a level 3 population is very different from the diet and ED or admitted to the level 3 center patients, in that presumably most of those patients do fine and don't actually suffer any negative consequence, the ones who are discharged from the level 3 ED. Have you looked at any sub-analyses of that population versus the admitted or died in ED population?
No, that's a very good question, because you can say this is not a cohort study. This is like a cross-sectional study. We only know where they receive care at the EDs, but we don't know what happened after EDs. That would be a good study, future study. What I'm trying to do, Nationwide Children's Hospital is managing 230,000 Medicaid children in 44 counties of Ohio, which means we can keep track of where they receive the care, what happened to them, because no matter where they receive the care, they all need to submit their claims and all this diagnosis to our Nationwide Children's Hospital. We have that database. We can link them to, link them together. I did got the data from our Children's Hospital. That's what we want to do. That's an excellent question. So because we really don't know what happened after that. Yeah. Okay.
I think the evidence that you presented was very compelling for field triage to level 1 and 2s conferring a mortality benefit. Can you talk about what's there about transfer? So if you show up at a level 3 or a non-trauma center, what the mortality benefit would be of then secondarily transferring to a higher level of care, because there's a tremendous time, resource, and potential duplication effort that's that, as well as by including the families that you're transferring from Wyoming to the closest trauma center, because there's an assumption I think made that that's a desirable thing in the way you do conceptual without the secondary transfer.
Yes.
The related question is, do you actually know when a patient is transferred out of a level 3 or not trauma center team, where they go? I know the publicly available NEDS data just is tricky. And restricted to the file.
Yeah, there's several issues related to that. I want to share with you. Do you know Dr. Fred Rivera at Seattle Universities? He did a study comparing those transfer patients versus directly arrived patient at level 1, level 2 centers. Result from his study such as there's no huge difference between those transferred and non-transferred. That's one thing. Second thing I want to say about this field triage, usually the EMS personnel, they will follow those field triage guidelines. If it's a severely injured patient, they send that to trauma number 1, number 2 center. But but the situation in the field is more complicated in that. Here I didn't have data about helicopters, helicopter transfer in the remote area, transfer those patients located on the borders of 2 states. There's West Virginia, Ohio, Pennsylvania, and there's another issue is I think we want to do a studies to look at the previous guessed 18% of those patients are transferred by EMS. Majority of them are transferred by the family members. So nobody really look at those 2 groups, those EMS transfer person versus patient family transfer person. So the assumption is if the family member do not know the field triage, probably the proportion of those patients who transferred by family member need the higher level of care is significantly higher because they didn't follow the first field triage. Yeah, there's a lot of, like I said at the beginning, there are a lot of unanswered questions, but I can see this is a very significant issue, and there are a lot of things need to be done.
So John, would you assume that
not necessarily. We don't know. But I assume probably a lot of higher proportion of those patients who transfer by a family member need the second triage. So,
One caveat I might put to that 18% number, which I'm not familiar with those data, but I would imagine that an ISS greater than 16 is going to be challenging for family members to
yes.
A pretty severely injured population that, could certainly carry them into the car, but, I would imagine that the EMS transport rate for that is quite high.
Yes. I want to emphasize here, I want to point out that IS is going to go to 17. That's our criteria. But EMS person, that's the after fact figures. Because EMS person in the field, they will use the 4 steps to assess the patient. They do not know the ISS scores there. That's a very good point. Good recommendations. But also there's whether that ISS, we are doing a study trying to match the injury severity score with those 4 steps. We have to, that's what we are trying to do.
One quick question. It'd be interesting to look at the capacity if you say, I'm just thinking of the combination of the ISS 16 with traumatic brain injury. Maybe those are the people that should be transferred rather than, you know, if you're going to take care of under triage, maybe that would be the most important group to focus on. So I would just wonder if that might be something that would be interesting to model. If you just said what would be the capacity increase for ISS 16 and over with TBI only.
Yeah. So that's a very good suggestion. Yeah.
Any other questions? Thank you very much.
Thank you very much for coming. Yeah.